Are we live? Are we live now?
Could we please check if we are live? Yes, yes, we are. Thank you so much. Thank you, Pastor Teresa. Good.
Okay, we are sorry about the disruption. So can people see on Facebook now?
Yes, they can see us on Facebook. I can see the comments coming through, so that's good.
Okay, good. So sorry about that. We were talking about the symptoms of menopause, and Dr. Kwashingisa kind of went through the 5 systems that menopausal symptoms show in. So I'm going to ask a follow-up question, Dr. Kwashi. So let's say you said that the average age for most women to experience menopause is about 51 years, and in Ghana it's about 47 years. So how about, let's say, a 30-year-old or maybe a 35-year-old who stops having her period? Is that menopause?
You're muted, Dr. Kwashi. You're muted, Dr. Kwashi.
Hello. Yeah, sorry. Yeah. So I'm saying that unfortunately, I'm not really hearing you very well. Oh, okay. But I gather you're asking me a follow-up question to the symptoms of menopause.
No, the question is, you said that the average age for a woman to experience menopause is 51, and in Ghana it's about 47. So I'm saying for a 30-year-old or a 35-year-old who stops having her period, is that menopause?
No. So if before the age of 40 years is not necessarily, at 42 is not necessarily menopause. There are hormones you can have.
I think she
every month. So the fact that your period does not come does not necessarily mean that you've gotten menopause. Menopause, like Dr. Yah said, is your final period, after which you have 12 months of no periods. And so that is what we define as like your final menstrual period. If you're a young person and your periods have stopped, and they stop for that, have to do laboratory investigations to find out, are we really menopausal, or it's just from hormone abnormalities that are causing us to have irregular cycles.
Okay, so I think we'll move on to the next question.
Maybe I can just expand on that a bit.
Okay, sure.
So like Dr. Kwashi Ngesa was saying, if you stop having periods before the age of 40, you need to do some blood work. But if the blood work shows that your menopause hormone is high, which we call FSH, or follicular stimulating hormone, if that level is high, then you are deemed to be in a situation called premature ovarian insufficiency, which means that your eggs are behaving old when you're not that old. So if your period stopped before 40 and that FSH is high, then you're in premature ovarian insufficiency, and you should seek help, because much as we cannot cause the eggs to return, you may need to be on hormone replacement therapy, because you will start having low levels of estrogen at a very young age, which will then have consequences later in life, like heart disease, bone loss, and so that needs to be treated.
Right. So, Dr. Kwashi, can you hear me?
Yes, can hear you.
Yeah, good. So my question question goes to you now. Is it possible for women who've experienced menopause to still bleed?
Okay. So ideally, which is that you've had a final period and have had 12 months of amenorrhea, we do not expect you to bleed subsequently. When you do get that, that's if you're not on hormone replacement therapy or menopausal hormone therapy, we do not expect you to bleed. So,
okay, Dr. Makwakani, I think she got kicked off. So can you answer that?
So, like Dr. Kwashi was saying, after you've had 12 months of no period, you should not bleed. So if you have any bleeding, it warrants a full investigation. You have to see your doctor. You will need the baseline pelvic ultrasound and what we call an endometrial biopsy or a sample of the lining of the uterus. Because when women bleed after menopause, it could be a signal of, pre-cancer or cancer of the lining of the uterus. Not to alarm women, we must say that the commonest cause of bleeding after menopause is actually not cancer or pre-cancer. It's because sometimes your lining is too thin. It's almost like the lining is so thin that the vessels beneath it bleed. However, because uterine cancer can present with bleeding after menopause, if you have any bleeding, it warrants a visit to the doctor and a full assessment.
So Dr. Koshi seems to be experiencing some network issues, but she will just be jumping in.
keeps cutting off. Yes, sorry. I think it's my internet. It just keeps going off. So I was saying that if a postmenopausal woman did have a bleed, it's important for her to visit the hospital to ascertain why she's bleeding. We never want to assume that a postmenopausal bleeding is normal. So if you do have a bleed and you're postmenopausal, you should visit the hospital and see a gynae.
Okay, so Dr. Mankwa, the question is, so how long do the symptoms of menopause last? I mean, as you said, menopause is a single point in time, but then these symptoms that we've discussed, may last a while. So how long do they last, and when should somebody be worried if let's say the symptoms are lasting too long? And then the next question will be if you can go through how we treat all the different aspects, the 5 systems that Dr. Kwashi discussed.
So, how long the symptoms last is $1 million question, because most women are wanting to see light at the end of the tunnel. So when they're having these symptoms, they're thinking, oh, it's going to be fine. In 6 months, I'll be okay. In a year, I'll be okay. But it can drag on quite a bit. In the past, we thought the symptoms lasted just 5 years and that was it. But we've known over time that, people will experience these symptoms anywhere from 5 to 7 years and even into 15 years after that final menstrual period. So I do have patients in their 70s and 80s who are still having hot flashes. But the question is, having a hot flash is not a dangerous thing. The question should be, how tolerable are those symptoms, right? Because if you have symptoms and they're not bothering you, you don't intend to medicalize this whole menopause thing. So if you have symptoms and they're not bothersome, that's fine. It may disappear eventually. But if they are still bothersome, then that's where the question arises. Do I get treatment or not, right? So the decision to get treatment for your symptoms is based on how much it is affecting the woman's quality of life. So let's say the vasomotor symptoms, or what I'll move forward calling hot flushes, just for the sake of easy explanation. So with the hot flushes, there are different approaches we can use. We can use just behavior and lifestyle modification sometimes. So if you live in some places in the world where it's cooler and you tend to wear a lot of warm clothing like turtlenecks and whatnot, you may realize that that's not the best thing. At some stage, you'll have to start dressing in layers, So wear a tank top, wear a sweater on top, and then that way, if you overheat, you can just, take off one layer, right? And then you cool down. This is where women also may be living in the house with other people and trying to get people frozen, literally, because the woman wants a house temperature really cool where everybody else is feeling frozen. They are just comfortable. So we want to make sure that we have a cool environment to cool down in, dress in layers. There are also some things that can trigger hot flashes. Like, you enjoy your spicy food, but you're going to pay for it. So you have something spicy, it can bring on the hot flashes. So if that's a bother, you may want to avoid that. You may also notice that some women actually drink alcohol. Like they'll have a glass of red wine and they will start to get hot flashes. A cup of coffee, they'll start to get hot flashes. So kind of just stay away from those things that you have identified as triggers for you. But outside of that, very few women would just respond to their lifestyle changes. And this is where they may start to seek help for treatment, right? So looking at these vasomotor symptoms, the one effective treatment is menopausal hormone therapy, which in the past was called hormone replacement therapy. We've gone away from the word replacement because we don't mean to replace a woman's hormones, right? We're just trying to treat her symptoms. So it's not mandated that she has to replace a hormone. So we give menopausal hormone therapy in the form of estrogen, which comes in various formulations. They can be given as pills by mouth. They can be patches or gels we use to be applied on the skin. Now, estrogen, however, can cause the uterine lining to grow, right? So we counteract that with another hormone called progesterone. So we give two hormones for women who have a uterus. If the woman has had a hysterectomy where she no longer has a uterus, then we give her only estrogen to counteract the symptoms. So this is what we use to treat the hot flashes. Now, there are some herbal remedies over the counter, which I would caution a woman that it actually does not provide relief of symptoms. So I've listed them there: ginseng, wild yam, flaxseed, all those things. You're just pouring your money down the drain. Anything you take will have a placebo effect, 30%, even if it's an empty pill, like there's no medication in it, you will feel 30% better. So most of these women would experience improvement in their symptoms to some degree, but it doesn't last long. And after a short while, they just tell you, you know what, my hot flashes are back. So we don't really advocate these herbal remedies. So we've talked about hormone therapy or menopausal hormone therapy. There are also some non-hormonal treatments that we can give, okay? Not every woman is a candidate for hormone therapy. For example, if you've had a stroke or a heart attack, or you've had a blood clot in your calf that has been thrown up to your lungs at some stage, or you have some cancers that feed off estrogen, then you are not a candidate for menopausal hormone therapy. And in lieu of that, we would give other non-hormonal medications that have been listed there. There is gabapentin. Gabapentin is typically used to treat fibromyalgia, migraine headaches, and seizures. But in certain doses, it can relieve hot flashes quite a bit. Clonidine, the second drug, is an antihypertensive that may also result in reduction in the hot flashes. And then the third group there are anti-anxiety antidepressants, which when used in lower doses can cause about 60% reduction in the hot flashes. So the option number 1 and 3 can cause about 60% reduction in hot flashes, which is quite desirable for women who cannot take menopausal hormonal therapy. So that is how we treat the vasomotor symptoms. Now, for things like the sleep disturbance and the mood changes and the irritability that comes with menopause sometimes, once you give the hormone therapy, if it's a ripple effect, if the woman is having sleep problems because of night sweats, right? Then once you take away, you give the hormone therapy and the night sweats go away, then her sleep will be better, right? If she's irritable because she's not having a good night's sleep, so she's not the nicest person in the morning, if you treat the night sweats and she's more rested, she'll be nicer in the morning. So it could be like a ripple effect. So often the estrogen, progesterone, which is menopausal hormone therapy, can resolve those other secondary symptoms. But sometimes you have to treat those separately. Some people may end up being on sleep aids if their sleep is really still bad, which they would have to see the doctors for. Now, the other group of symptoms, which are the genitourinary symptoms, which are the symptoms related to the bladder and the vagina, right, are treated actually with local treatment in the vagina. So in the vagina, we give estrogen treatment. That is different from the estrogen we give by mouth and by skin, right? These are local treatments in the vagina, and they can be used by women who have even had strokes or heart attacks. You can use the local vaginal estrogen. So it is, there are treatments that come in the form of creams. There's also tablets you can put in the vagina. And there's also a ring that can be inserted in the vagina and left there for 3 months and slowly releases the estrogen into the surrounding tissues. Like Kwashi had mentioned earlier, in menopause, due to the loss of elasticity in the vagina, the woman can have narrowing and pain with intercourse. So it's important that frequency of activity is kept up, because having intercourse is a way of stimulating the tissues in the vagina, improving blood flow to the area, and making the tissues more healthy. So we use local vaginal estrogen, we use frequency of activity, and also a lubricant, which most people call a gel, also helps during intercourse. So those three things are the mainstay for treatment of the dry pain with intercourse. In a similar manner, the vaginal estrogen will also support the bladder tissues, and may help improve the symptoms of the urgency. It doesn't help with urinary leakage, but it does help with that symptom of urgency. So this is a little acronym I used when I presented the other time. I made it up myself. It's called My Love. So you need to moisturize the vagina with estrogen, you need to lubricate when you're intimate, and you need to use the vagina, which is having frequent intercourse. And if women cannot have intercourse because it's too painful, sometimes they would need pelvic floor therapy, because your vagina is narrowed so much that it's painful to accommodate the husband's penis. And as such, they would go for pelvic floor therapy, where they give them dilators to slowly stretch out the vagina again. So it's sad that something that was so natural now becomes a big chore, if this is not addressed early.
So let me kind of go to Dr. Kwashi as a follow-up. So, for example, in Ghana, I mean, I think in the Western world, it's easy to discuss these topics. So, in a place like Ghana, for example, Dr. Kwashi, how do you educate women who are postmenopausal regarding these issues? Are these things that, like when you talk about the lubricants, for example, or moisturizing the vagina, are these things that are easily available, and are these things that you can easily discuss with your patients? Oh, Dr. Kwashi, you are muted.
It's muted.
I think I'm better now, yes. So I'll say that when it comes to menopause, generally, people do not like to talk about menopause. There's some social negativity that comes with talking about menopause. Nobody wants to be associated with menopause. So you have lots of women who are coming to you and telling you symptoms that are surely menopausal. And when you say, this is perimenopause, because they are just assume that menopause will come in a blow, boom. They do not get the concept of the perimenopause. And so when you start to educate people and talk to them about perimenopause and that's what they're having, people don't want to hear it. They don't want to believe that they've got perimenopause, no. But these treatments are available. Lubricating, yes, for people who are educated and have read and want to use it, they are almost always available. The thing with menopause is it's a very individualized stressing is coming in with, and the education you are given to the person and how the person assimilates what you are telling, and then you kind of get a common line by which you decide this is the treatment. Are we going to go hormonally? Are we going to go alternatively? What are the other forms we can use? And here, we don't talk enough about menopause in Ghana. It's something that we don't talk. I keep saying we don't talk a lot about menopause. There are so many things and so many drugs that are available menopause hospital and talk about it. But there are several forms of MAT and menopausal hormone therapy that are available that can improve the quality and make you feel better, that can be given. So it's not really a question of non-availability, but about people wanting to come forward with their symptoms and believing that there's something that can be done about it for them.
Thank you, Dr. Kwashi. Now, my question is, why do you think menopause is not really discussed, like you're saying, in Ghana and I'm sure other parts of Africa? Is it because of the fear of being ridiculed? And if so, what do you think the attitude of men or the men in our lives or husbands and the community as a whole, what should our attitude be towards women who are perimenopausal and postmenopausal?
Yeah. I think it has to do with the sociocultural perspective of who a menopausal woman is. You know, we've created this figuring of a menopausal woman who is not understanding, always angry, you know, doesn't understand anything, forgets everything that is said to her, very difficult. And so in the people's mind, when you say menopause, they are thinking, oh my God, am I becoming that person? And so they don't want to be associated with that stereotype they have in their mind for who a menopausal person is. I think it has to start from a point of educating. Education is what's going to break all the myths that are associated with it. And educating not just women, but educating everyone in general. So people understand that it's a normal physiological process. And you know, so the more help you offer, even psychological help that you offer, tends to improve how people deal with the menopause. And for the women themselves, for them to understand that there's treatment available, it has not got anything to do with spirituality. And when you take the medications, yes, people have heard all kinds of things about medication, but there are treatments available that can help you through the menopause. And that is going to help. Everyone has a sister, a mother. If they know what it is about menopause, then you can offer help. When you see people are suffering with symptoms of menopause and are not yielding to come to hospital, you can also educate them to get them to come and seek the help that they can most readily get.
Yeah, Dr. Wankwa, can you add something to it, maybe from a Western perspective or even from a developing country perspective?
Yeah, so I think that definitely the social cultural environment affects a woman's intent slash, you know, tendency to talk about these issues. In the Western world, it has even been determined that you actually need to ask about vaginal dryness. We have put us all in the bathrooms in our clinic saying that, do you experience itching in your vagina? Do you experience pain with intercourse? Talk to the provider, right? There was a study done that showed that if you actually did not ask the woman, are you sexually active by way of vaginal penetration? Are you experiencing some dryness or pain? They actually won't bring it up. And this is even in the Western world. So providers need to ask these questions. And when these questions are asked, it opens the door for the woman then to kind of, yes, she's vulnerable, but she knows she's in the right place. You've asked because you're interested. And this is how you can get her to bring up her concerns. I also think that just the general public education is a big thing. And in the developing world, things are changing, but the focus has been on, you know, disease prevention, things like that. So these quality of life things are ranked, you know, down the list. People are trying to figure out, you know, where's my next meal coming from, that kind of stuff. So pain with intercourse is not something they're going to talk about. And even if you prescribe the treatment, you talk about affordability, because even here, we're restricted by the kinds of treatments you can offer. When I'm trying to treat, the first question I ask is, do you have any insurance? Do you have any secondary insurance that pays for your medications? Because if you do not, this is the option. These are the cheapest. And then if you do, these are the other ones you can have. So affordability is always a big factor. even in the developed world, also in the developing world, I can see how that will be a challenge. So it is, yes, the general education providers as well need to be educated to ask these questions, which goes a long way.
Thank you. Dr. Kwashi, what is PMS, premenstrual syndrome? We hear people talk about it so much. What is it, please?
All right. So PMS is basically premenstrual syndrome, or the same as premenstrual dysphoria, and it's usually a group of symptoms that are both psychological and physical. Psychologically, you have so mood changes, cognitive, physical. This of them is irritability. That's the main.
Okay, I think she's out. So Dr. McQuarrie, maybe you can.
Okay, so like Dr. Kwashi was saying, you have those psychological / emotional symptoms, and then there's physical symptoms. So just to mention that PMS typically happens, about 10 days, anywhere from ovulation to the onset of the period, right? So if you have a woman who has a 28-day cycle, day 14 is around the time she's going to ovulate. And as such, the PMS symptoms can happen from that day 14 to when the period starts. So about 10 days before the period, within that time frame, she'll start to experience these emotional changes. She can be crying for nothing. She will have a bit of anxiety, mood swings, irritability. She wasn't provoked much. She gets angry, right? And then the food cravings, right? This is when they want to have some chocolate. They want to have this or that. So those are the emotional things. And it's just due to some hormone changes that happens in that part of the cycle. It's believed that some women's progesterone levels are swinging up and down in that phase, and that's what predisposes to that. Associated with that as well would be the bloating, the extreme breast sensitivity, bowel disturbances, fluid retention causing them to feel a bit of weight gain. And then once the period starts, those symptoms resolve. So if those symptoms are persisting beyond, the period starting, then you start to question if this really PMS or not, right?
Okay, Dr. Kwashi,
Yeah.
I guess you got kicked out. So yeah, Dr. McQuarrie has kind of gone over. I don't know if you want to add anything else to it.
Sorry, my internet is giving me lots of problems this evening. So can you just go over the question again? I didn't hear what you said.
Oh, so she kind of continued from where you were and discussed.
Yes, I realized. Yes. Yes.
So how does PMS relate with menopause, Dr. Kwashi?
Okay, so PMS tends to we find that in the perimenopausal period, like Dr. Ya said, that's the transitioning from normal regulatory cycles to getting to menopause. It worsens the symptoms of PMS. So some people may get it worse off than they were having before they got into the perimenopause. And there's a much severer form of PMS, which we call the premenstrual dysphoric disorder, which is like a more extreme form of everything we've talked about, the symptoms I went over and Dr. Ya went over as well for menopause. For each of these ones, we always say, just come to hospital, see the right person, and treatment can be given for it.
So this question goes to maybe Dr. Amankwa. What about the hair loss and skin changes that happen, after menopause? Is there anything that can be done about it?
So the hair loss is multifactorial. There's many reasons why women can have hair loss, but we know that with the loss of estrogen, that the hair becomes thinner, right? Estrogen is good for the hair, is good for the skin, is good for the blood vessels. So with menopause, women start to lose hair. However, we also need to factor in any family history, because if you have a family history of balding, right, then that may also be more pronounced in menopause when your estrogen levels go down and the hair thins out. And then there's a family history, then that may also start to express itself. So it depends on the pattern of hair loss that would direct therapy. So if it's just estrogen deficiency, sometimes it's more of a diffuse, thinning of the hair. People are like, I comb my hair and everything's on the floor. My hair feels much thinner. But there's also that aspect of, if it's a family history of balding, then you may start to have a male pattern baldness or female pattern balding, right? Which all contributes to it. Now, so what can be done to treat it? It depends on the cause of it. So you will notice that, of course, being African background, I would say that, sometimes all the products we use in our hair, your hair could handle all these, chemicals when you were younger, but suddenly when you get to menopause, you're like, oh my God, like this is not working, my hair is breaking, so you may have to make some modifications with the products that you use on the hair that are going to be more gentle. And there is a topical agent that can be used. It's called minoxidil. Depending on the pattern of hair loss, minoxidil can be used topically on the hair to stimulate the hair follicles, improve the blood flow to the area, and help to grow hair. But it works more for patchy areas, You can't use it when you have the general hair loss thing. There is also some medications that can be taken that block the effect of the male hormones on the hair follicles. These are all medications of different categories, but they block the effects of androgens, which are the male hormones on the hair follicles, and minimize the rate of hair loss. In like manner as people would have hair loss, they may start to notice more hair growth in unwanted areas, like on the chin, more coarse hair growth, and that's all due to the effect of the androgens on the hair follicles. Not much can be done for the thin skin except do your usual healthy stuff. We wouldn't advocate people starting hormones. Sadly enough, much as hair loss is very distressing and skin thinning and wrinkles are not a nice thing we want to go through, we don't advocate starting hormonal therapy for this kind of for these kind of symptoms, because you always have to weigh the risk benefit. Hormones do come with some risks, and one of the things is not beautification, sadly enough.
Thank you, Dr. Yeah. Dr. Kwashi, so what's it about weight gain and menopause? Did you get me?
Oh, she got off.
Dr. Yeah. Dr. Yeah.
Okay. So it is not imperative that women are going to gain weight in menopause, but it is very common. And the reason this happens is that the woman's metabolism changes, right? So the weight gain a woman experiences is a balance between your caloric intake and your ability to burn off, right? So if you're not burning off as much as you used to, you will gain weight. So what happens is that in the menopause, women's metabolism slows down. The same amount of food you were eating 5 years and 10 years ago, you eat the same amount. You just need to smell the food cooking and you gain weight, literally. So you have to work extra hard against it. So it means we don't want people monitoring their caloric intake, but everything that goes into your mouth, you have to think twice. You may have to skip that ice cream, you may have to skip the dessert, because you will not burn enough as before. And have to pick up the physical activity as well in order to balance it out. So it is the metabolism. It starts even after age 40. So you may be in the perimenopause and not having had a cessation of your periods yet, but you'll start to notice that the weight starts to pack on slowly. And sadly enough, that weight is not even distributed. It would be nice if it went into areas that you want it to go, but it all goes into the central part, right? So you kind of suddenly feel like you're 3 or 4 months or 5 months pregnant when everything else is wasting away, but your belly is getting bigger. So that's the reality about midlife weight gain. Mm-hmm.
Okay, so moving on to, as Dr. Kwashi talked about what menopause was and the effects, she mentioned kind of 5 system areas. Okay, so what are some of the heart problems? She talked about cardiovascular problems. So what are some of the heart problems that patients can have? I think it was mentioned somewhere about cancer risk and then osteoporosis. Can we dive a little deeper into those things? Let's start with the heart one. I think Dr. Ya can start, and then Dr. Kwashi can.
Maybe since Dr. Kwashi is on now, why don't we get her to go in case we lose her again?
Yeah.
Before my internet disappears again, yes. So you want us to go into the heart problem. So
Yes.
with respect, said estrogen or the female hormone is found to be anti-inflammatory, meaning that it tends to protect you from inflammation in certain parts of your body. And so when you become menopausal and you lose your estrogen levels start to go down.
Okay, I think you can take over.
So as the estrogen levels decline,
Go on, Dr. Kwashi.
Yes, I'm so sorry, but I don't know what's happening to my internet
That's all
today.
right.
And I keep breaking. Yes.
That's okay.
Third world problem. Yes. So I don't know if Dr. Ya was taking.
No, you go ahead. You go ahead.
So, well, generally, when you start to lose your estrogen levels start to go down, then so while you have estrogen, we say that it protects you for a woman who's out. If you coronary heart disease, valvular risk of getting clots in the legs, what we call thrombotic events and whatnot. But when you become menopausal and estrogen goes down, your risk becomes just as equal as the man your age. So you also have the same risk for getting coronary heart disease, embolic phenomenons. All of those increase as you become menopausal because your protection from estrogen is no longer there. So that's the relationship between coronary heart disease, cardiac disease, and menopause. If you were to take, I think you mentioned cancer, or I didn't hear that right.
Yeah.
If you were to take cancer as well, yeah. So if you were to take cancer as well, for estrogen, when estrogen goes down, and now you have a loss of estrogen. So in the postmenopausal period, people are at risk for getting more of endometrial cancers, and so the lining of the uterus is more likely to undergo changes, or we say cancerous changes, and start to grow out of normal proportion, and they are at risk for those kinds of cancers. For other cancers, when we talk in the postmenopausal period, most people relate it more with hormone replacement therapy. But like we'll go on to find out, it's not cast in stone that hormone replacement therapies, will cause cancer for you necessarily, because by far the benefits of hormone replacement therapy outweigh the risk factors that are involved in or the risk associated with hormone replacement therapy. I think we also said about bone. So bone, I think I talked about that already, that because of the estrogen generally helps to keep the balance between your bone breaking down.
Yeah, Dr. Ya.
I just also wanted to add on a bit to what Dr. Kwashi said about the cancer. So, with age, you will think that your estrogen levels are going down. So the cancers that are estrogen dependent, right? So you can divide cancers into those that kind of feed off estrogen and those that don't. So if your estrogen levels are gone down, why are women getting more breast cancer? Because estrogen is one of the hormones that plays a role in breast cancer, right? But I would say, again, going back to the issue of weight, weight is one of the biggest underlying risk factors for most of the cancers in postmenopausal women. So as a woman is getting older, as you get older, the risk of high blood pressure, let's say, goes up, right, just by way of age and cholesterol and things like that. So if you're older, those baseline risks are going up. And then you add on the weight gain, which fuels everything, and then splash in a little bit of other risk factors, and then it just escalates. So just the fact that we're getting older, we're depleted of estrogen, increases our risk for certain things. Weight gain increases the risk of developing high blood pressure, diabetes, and as such, even women who are overweight, what happens is that your body takes a little bit of testosterone and converts it to estrogen in your fatty tissue. So your testosterone now becomes converted to estrogen, and the estrogen can then go and stimulate your uterine lining and cause cancer. So women who are obese and hypertensive and diabetic actually have a higher risk of uterine cancer. So it goes back again to the lifestyle modification and actively trying to, keep our bodies in check so we minimize the risk factors. Those can be modified, right? So things like cancer of the cervix does not increase with age because it's actually most of the cancers are related to the HPV virus, and unless somebody has new sexual partners or some different risk factors, the risk of cervical cancer is not going to go up with age. But the risk of breast cancer increases with age, endometrial cancer increases with age, you're obese, especially. Then we talked about osteoporosis, right? So the lack of estrogen causes the bones to be thinner. Now, you don't feel the osteoporosis, sadly enough. So it's not aches and pains. The aches and pains are arthritis and whatnot. But osteoporosis, you do not feel it. But if you were to sustain a small injury, you could end up with a fracture. And the way we minimize osteoporosis is to ensure that we're taking vitamin D. So every woman who's postmenopausal, especially living in a temperate world, should take vitamin D, 1,000 to 2,000 international units every day. We need to make sure that our diet is rich in calcium. So if you're not a milk or yogurt drinker, you can get it from things like cheese, from almonds, from things like sardines, from almonds, leafy green vegetables will give you calcium. And if you cannot make it up, then you need to take a calcium supplement in addition to vitamin D. So those are the two essential supplements that women need to take, to maintain the bone health. And then weight-bearing exercise. So, walking, brisk walking. You don't need to go to the gym. Brisk walking, lifting some weight, even your grocery bags. That sedentary, attitude we have as we get older. And I can say that in the developed part of the world here, you don't have that extra help. You have to do everything yourself. You go to groceries, pick them up, carry it home into your car, into the house, do everything. But I must say, having grown up, in Ghana, it's very normal that as you get older, you have lots of people to help. Hey, do this, do that, do that. And you're sitting there, with limited physical activity. So that is not good for the bones. That's not good for the osteoporosis and not good for the physical activity part. So we need to consciously move.
So can you maybe let's go back to the heart disease part. We talk about different things that we can do to improve heart health, especially in postmenopausal women. Can you kind of talk a little bit more in detail about kind of what women can do to improve their heart health?
Absolutely. So this divides it up into things that you can modify, that's within your control, and things that you cannot modify. For example, if it's a family history of heart attacks and high blood pressure, sometimes despite what you do, you try to watch your weight, you try to eat healthy, but because you have this strong family history of high blood pressure, you end up developing high blood pressure. So that one you cannot change. You cannot also modify the fact that you're getting older, right? So for those that you cannot modify, don't lose any sleep on it. But for the ones that you can modify, you need to go at it aggressively. So if you smoke, you need to try and cut down or stop, right? If you have been diagnosed with diabetes, you need to ensure that you are taking your medication, that you are, exercising to keep the weight off. If it's high blood pressure, please take treatment. Get your blood pressure checked regularly, you know. And if you've been diagnosed with high blood pressure, your doctor may say try and modify your diet, try and exercise. But sometimes, despite doing those things, your blood pressure is still high and it warrants medication. Please do take the medication to keep the blood pressure down, because if you don't, then your heart vessels are all going to get crunchy and block, what we call plaque, and that increases your risk for heart attacks and strokes. If you have high cholesterol, sometimes high cholesterol is familial, right? It's a family history. Some people just, whatever enzymes it needs to break down the cholesterol, or some genetic thing going on where the cholesterol is high, they can watch their diets, cut down the fatty foods, eat, you know, fresh homemade meals. If you do that and still your cholesterol is high, you may have to go on cholesterol, you know, modifying medications, and do go for it if that's what's needed. The weight we talked about already, we're going to try to maintain or even lose some weight. I must say that after menopause, sometimes it's a struggle losing weight. But if you can maintain, it's a big thing, because if you don't try to maintain, every year you're going to pack on a few pounds, and before you know, you're 40, 50 pounds over. So let's say if around menopause you gain 5 kilos, don't lose sleep over it. If you can stop gaining, you're winning, right? So you may not be able to get into those clothes you were wearing when you were 35, but if you can stop gaining, then you're winning, right? And stress, right? Stress is, so far as we're still alive, we're gonna live through stressful times, you know. But how do you relieve your stress? Do you exercise? Do you have other things that can help you relieve stress? Those are all ways we can modify the risk of heart disease.
Yeah, Dr. Yasu, looks like it's just you. Dr. Kwashi sent her apologies. Unfortunately, she can't get back in because her network keeps dropping. So thanks so much for joining us, Dr. Kwashi. And if you are in Ghana, please visit her at Midway Hospital in Achimota. I know they are providing great services. Dr. Kwashi was also my mate in Wesley Girls High School. And I want to say thank you to her for joining us and honoring this invitation. We really appreciate it. So, Dr. Ya, my question to you now is, should every woman who is on menopause have hormonal replacement? Should they go to that sort of treatment, or?
I would say no, it's not for every woman. So, like we said, menopause is not a disease, it's a natural stage the body goes through. And if your symptoms are not affecting the quality of life, if you don't have hot flashes that are bothersome, then you don't have to go on hormone therapy. But if you are experiencing hot flashes, night sweats that are bothering you, you cannot sleep, you wake up, you can't function, your productivity at work is lower, then it's something that can be taken. We do a risk assessment. We make sure that even if you have high blood pressure, it's well controlled. If you have high cholesterol, it's well controlled, right? We look at all the things that could make your risk of taking hormones high. For example, when you start taking hormone therapy, there's a slightly increased chance of blood clots, you know? So if you have high blood pressure or diabetes that's untreated, or high cholesterol, those increase your risk of clots and heart attacks. So all those things have to be modified. So we do a risk assessment. If we determine that, you know what, your risk is very low, and that you will benefit, then it's something that should surely be considered, because it can make a huge difference in the woman's quality of life.
So you talked about one of the side effects being developing blood clots. Can you talk about the other side effects that taking hormonal treatment can cause?
Yes. So during the early phases, so let's break them up into like immediate side effects and the long-term risks, right? So with the side effects, women may sometimes experience some breast sensitivity, because if you haven't had hormones in your body for a while, you're in menopause, no estrogen, and suddenly you get exposed to estrogen, your breasts may feel a little more sensitive, like they do right before a period, right? Or you may feel a little bit of bloating. Or sometimes when we start hormone therapy, because your uterine lining can get stimulated, you can also experience some light bleeding. So all these things are normal during the first 3-4 months of hormone therapy, and eventually should settle. But then let's look at the long-term side effects, risk factors. So during the first 6 months to a year, slightly increased risk of blood clots in the calf. And the way we decrease the risk of blood clots is to give the estrogen through the skin, right? Because there's tablets you can take by mouth, but then there's also preparations that can be given through the skin, like gels or patches. This is where the affordability becomes a big issue, because the preparations by mouth have to go through your liver to be broken down and released into your blood. And the liver is where we make clotting factors. So if you, let's say, have to take it by mouth and you're at increased risk of blood clots, then during that first 6 months, you can get a blood clot. But if you can take it through your skin, then you reduce the risk, right? So those are some ways we decrease the risk of blood clots. Now, the studies did show that if you don't get a blood clot within the first year of use, actually, you are fine. By year 4, women's risk is much lower than during the first year. So the blood clot risk is not something that persists or increases the longer you're on hormones, actually. It does get less if nothing else changes in your life and your health remains the same. But then there is also the issue of long-term use resulting in breast cancer, right? So studies have shown that the first 5 years, the risk of getting breast cancer is low. But when you stay on hormones beyond 5 years, there is a slightly increased chance of breast cancer. So just to give you an example, if you take 10,000 women, 450 of them, unfortunately, will develop breast cancer. That is a baseline risk, 450 per 10,000. If a woman goes on hormone therapy for 5 years, we have 20 extra cases per 10,000. So look at those numbers. So you go from 450 to 470, women per 10,000. So 20 extra cases. So yes, it is, but it's not a lot. If a woman goes on hormones for 10 years, you will be looking at 60 extra cases per 10,000, right? Hormones for 15 years, you'd be looking about 120 extra cases per 10,000. So the longer you're on, because the hormones stimulate the breast tissue. So the longer you're on hormones, the slightly higher the chance of breast cancer. So should a woman stop hormones after 5 years? No, she can stay on it, but you need to have your mammograms done to ensure that your risk factors are still kind of quite low. And at the earliest chance, for example, these hot flashes, they can get better with time. So once you start hormones, it doesn't mean you're condemned to hormones for life. So let's say after 5 years, when I ask my patients, are you still having hot flashes? They're like, no, I don't have a single hot flash. Then what we can do is we can drop the dose of the hormones a bit and see how they do. If they drop the dose and they're still okay, then maybe they're getting better. Then we can cut down and beat them up. For some women, though, the hot flashes will persist and they may have to be on hormones longer. So I would say that the breast cancer is one of the biggest scares. So anybody you talk to will say breast cancer, but again, it needs to be put in perspective. What are the underlying risk factors, and what are hormones adding on to that? The other thing is strokes, right? So as women get older, we talked about the fact that there is an increased risk of stroke, and with age, just because of high blood pressure, diabetes, hardening of the vessels, and all those things. So a woman in her 60s, mid 60s to 70s on hormones, her risk of stroke is a little bit higher than somebody at 55. So again, those are certain things that have to be considered. And the big study that was done looking at hormone therapy and the risk factors, it's called the Women's Health Initiative, showed that the risk of colorectal cancer, Professor Lai, the risk of colorectal cancer was actually lower on the women who are on hormone therapy. So it's not always bad. There are some benefits. Yeah.
Okay, so it sounds like for the most part, when we talk about breast cancer risk, that's very low. I mean, compared to background from the numbers that you quoted.
That's right.
Yeah, and the other lesson that I think is important is the fact that, I mean, most of the hormone replacement is really to treat the vasomotor symptoms, the hot flashes and stuff. And so if a woman who's postmenopausal is really not having hot flashes and those, or even if they are having it and it's not significantly affecting their quality of life, then they probably don't need to be on hormone therapy. Or if they are on hormone therapy, they can cut back and then eventually get off as soon as
that's right.
Possible. Okay.
I'll give you an example. Sometimes you have a woman who's been on hormones for a while. She's having a hard time coming off. sometimes what I do is I find out, are you planning on retiring soon? She tell me, you know what, I'm going to retire 3 years or so. And I'm like, okay, let's see if we can get you through the next 3 years. It doesn't mean when you retire, you're not going to have any life in front of you, but at least if at nighttime you're not sleeping too well, you can sleep in a bit in the morning. You don't have to be up and gone, by 6 a.m. and things like that, right? So the nature of the woman's job as well does determine whether people are going to be on stuff or not. I'm not to say that you don't need your mental faculties, but there's some jobs that require people to be a little more focused and sharp, in the sense that, and so if they're not sleeping well and they can't perform, that becomes a problem.
So let's kind of as the time kind of comes closer to an end for us, in terms of preventive health for postmenopausal women, I mean, in general, kind of what are some of the things that they need to pay attention to? I mean, not necessarily related to menopause, but I mean, in terms of preventive health, I think we've talked about some of the things, but kind of to put them all together in a way that people can at least understand.
Yes. So I think the biggest trap for women is women who in their younger years never had any health issues and as such never went to the doctor, right? So they got older and they still don't have any issues and so never go to the doctor. So there are women who have developed high blood pressure and didn't even know, and ended up having strokes or heart attacks because of high blood pressure that had been there for years. So I think it serves every woman well to have a routine visit to the doctor, at least once a year, have your blood pressure checked, your request for your cholesterol and your blood sugar to be checked, because you may develop diabetes and you don't even know, so have your cholesterol checked, have your fasting blood sugar checked, or your hemoglobin A1C, which is a measure of what your sugar control has been over the several preceding months. Then those are the basic things. Then you need your pap smear, right, done to screen for cervical cancer. So that is done every 3 years if you've had normal pap smears in the past. If you've had abnormal pap smears, you may need to do it, once a year. It depends on what you've been told. But the minimum is once every 3 years, you should have your pap test done, right? Then mammograms. So starting at age 40, mammograms can be offered to women, okay? There's been changes in the screening protocols over years, saying now, you don't have to have a mammogram until you're 50. But the teaching is that you can actually offer it to women at 40. I have picked up breast cancer in women in their 40s. So offer, and if she wants, then she can go ahead and do it. But otherwise, after age 50, you will need your mammograms at least every 2 years. And based on certain things that may be found on mammograms, you may need it more frequently, like once a year. So your pap smears, your mammograms, your blood pressure, cholesterol, fasting blood sugar, and then if you're at risk for things like osteoporosis, which comes with certain things, like if you have a family history of osteoporosis, or you're a very petite person, actually that increases your risk of osteoporosis. If your calcium and vitamin D intake have not been optimal, or you've sustained some fractures from a very small fall that shouldn't have caused a fracture, yet you had a fracture, you would also need your baseline bone mineral density. So those are some of the basic things. And I guess colorectal cancer screening as well, starting from the age of 50, that also should be taken care of.
So in talking about some of these, so for example, pap smears and mammograms and stuff, is there an age at which women don't need to have their pap test done anymore?
Yes. So I can say that in Canada and in the United States, we stopped screening with pap smears at the age of 70. Now, the reason for that is that, like I said earlier, cervical cancer is related to the HPV virus. And the HPV virus doesn't, your risk of acquiring HPV does not increase with age unless there's some new sexual behaviors, right? So a new sexual partner or a partner who has multiple partners can then bring, the woman can bring home the HPV virus. So generally, if you are the low risk, average risk category, and you've had normal pap smears in the preceding, you've had 3 normal paps, right? In the preceding 10 years, then at age 70, we stop doing the pap smears. Mammograms generally continue also into about 70 to 80. It depends. Most women around 70 will continue to do mammograms at least once every 2 to 3 years, but then it's deemed that the risk of breast cancer increases anyways. But it doesn't mean that you have to stop screening. So if the woman still wants to go screening, we would still recommend it even into their 80s. More so the women who are on hormone therapy. Mm-hmm.
I don't seem to have any questions coming from our audience. So, Dr. Ya, is there anything that you think we need to know that we've not probably asked any question on? We've not touched it yet.
I can't think of anything off the top of my mind. I think it's been quite exhaustive. You've been great with very stimulating questions for us, and yeah, I think that's all I can think of.
So I think, Dr. I thank you so much. And Dr. Kwashi is sorry that she had so much technical issues, but as that this is a very important topic. Every woman who lives long enough is going to experience menopause. And with that comes some of these issues that we've talked about over the last hour and a half. And I think it's important for all of us to understand that so that we can support our women when they go through this phase of life. I mean, as Dr. Kwashingisa said, this is not a disease. This is a natural progression of life. This is a natural physiologic change that happens in a woman's life. And with it comes a lot of challenges as we've talked about, but understanding the fact that these are normal physiologic changes, it's important for us to support our women. And secondly, for women who may be going through menopause, for them to understand that there's nothing abnormal about going through menopause. It's a normal phase of life, and you should not feel shy discussing some of these issues with your doctors and with your husband, for example, so that you can get the help that you need. Because obviously, if you are not, usually the mothers are the engines of the home. And so if the mother is not sleeping well and is irritable and is not comfortable, everyone else feels it. And so I think it's important for all of us to remove that stigma that's associated with menopause and support our women and support our families, because they play such an important role in our lives and in our families. And if we don't, then all of us are going to feel the brunt of it. Now, maybe for the last couple of minutes, so
I just put a question here.
Okay.
So,
there's a question. Okay, yeah. Go ahead, Mon.
He says, what about women who've had estrogen breast cancer and are told to go on hormone blockers, but are going through menopause and having symptoms from menopause? Should hormone therapy be considered?
So, if you've had breast cancer, it's an absolute contraindication to hormone therapy. So, unfortunately, such women should not take hormones, because if you think of it, you're trying to block the effect of hormones on the breast tissue to reduce the risk of recurrence of the breast cancer. So these are women who then would benefit from the non-hormonal alternative prescription medications that we had discussed, the one called gabapentin and also the one called venlafaxine or Effexor. So we would have to go to those prescription non-hormonal therapies. So such women cannot have hormones. They can have vaginal estrogen, based on how long it's been since their breast cancer and all that stuff, but they cannot take regular menopausal hormone therapy.
So I was going to ask, so we talked about the fact that postmenopausal women are prone to developing osteoporosis, and therefore they can break their bones easily with even small falls that shouldn't cause any problems. What can a postmenopausal woman do, or what can people do to, say, fall-proof their homes? What are some of the things that they can do to prevent them from having these falls, which normally will not cause a problem, but in a postmenopausal woman can cause a fracture?
Yes. So just before I answer that, I just also wanted to add on the fact that, when a woman has osteoporosis, it can occur in the spine, the bones of the spine, or in the hip, or, the other long bones. And if it's spine, osteoporosis in the spine, this is where women get all hunched over and shorter, right? So loss of height with age, and that hunched over look is could signal osteoporosis too. So to fall proof the home, so as women get older, stability becomes a big thing, and muscle strength. So people forget to talk about muscle wasting, as people age. So that is where weight bearing exercises and stability of those joints and strength in the muscles will minimize the fall. So one thing is to engage in these strengthening exercises. And the second thing is to simple things like even around the home. If you have an elderly patient that has rags, carpets, on the floor, those could be tripping hazards, right? So, getting up from the bedroom to go pee at night, a bathroom, and then they trip on the rag, they get a fracture. So things like that. So you need to look around the home, make sure the lighting is adequate, the flooring, even the kind of slippers they're wearing at home, right? If you're wearing socks that are slippery, you're going to fall. So you should make sure you have some footwear with some traction beneath it within the home, so you're not falling. The rags are not all over the place. The floors are not over polished, right? Because you have nice polished floors, but then they are slippery, right? So things like that.
Okay, thank you so much. I think our time is almost up. I will go to Maud to for any last comments and announcements.
I've got a last minute question coming through for you, Dr. Ya.
Yes, I see that there.
Yeah.
It says there was a mention about baldness. Will this apply if the family has a history of bald men? Are the women susceptible to this at menopause? Yes, actually. Yeah. So the baldness has this interesting hereditary pattern where not necessarily, but it's supposed to be inherited from mother to son sort of thing, and then passed on that way. So if there's a history of baldness, you have to look at your mother's side, and if your uncles are bald, then you most likely could get bald. Yeah.
Yeah. Yeah. Thank you for that.
Scary, right?
Yeah. Yeah. Thank you so much, Dr. Ya and Dr. Ingisa, for joining us this evening. I believe that there's so much we can learn from it, and so many practical things that we could do. So, like with the example of the rug that you gave, I know someone who slipped off the rug in her home, and she's had a fracture and had to have a surgery just for that purpose. So these are little changes that we could make at home to prevent such things from happening. Yeah, he says it's scary. So thank you so much. Now, viewers, it seems like so in the UK, our time has gone forward. So it looks like it did affect our viewership tonight slightly. But from next week, I just want you to know that we will be starting at 8:30 in the UK. That is 7:30 in Ghana and 3:30 Eastern time, right, Dr. Lai?
I believe that it will be two. Wait, I think it will be different. Okay, so 8:30. Yeah, so that will be 3:30 Eastern time and 2:30 Central time. Yes.
Good. And then 7:30 for Ghana. So please remember the time, and it will be on our Facebook page and on the flyers as well. Thank you so much, and see you all next week. God bless
Thank
you.
God bless you. Bye-bye.
Dr. Ya, if you could just